Okay, let's picture something pretty uncomfortable. You know, that sharp, stinging pain when you go to the bathroom,
Uh-huh.
and then you see that little bit of bright red blood on the toilet paper afterwards.
Yeah, definitely not a pleasant experience, and it's something quite a few people run into, unfortunately. It often points towards anal fissures.
Exactly. So that's what we're diving into today, anal fissures. Think of this as like a focused revision session, hitting all the key points you need to know.
Right. We're drawing on the usual reliable stuff, best practice guidelines, the Oxford Handbook, McLeod's, trying to make it clear and hopefully memorable.
Yeah, our mission is to get a really solid handle on these small tears that, well, can cause a surprising amount of pain.
So let's start right at the beginning. What exactly is an anal fissure? Define it for us.
Okay, simply put, it's a small tear, like a little crack, in the lining of the anal canal. Not a huge wound, but definitely painful.
And they tend to show up in a specific place, don't they?
They do, yeah. Most often it's in the posterior midline, so the back edge of the anal opening, if you like. Seems to be a common spot.
Got it. And the main thing someone notices.
Well, as we said, that sharp pain, especially during a bowel movement, and then seeing bright red blood, hematochezia, usually just when wiping.
That bright red is a clue, isn't it? Tells you the bleeding is happening right near the exit, basically. Helps narrow things down.
Definitely. Okay, so that's the what. Let's move on to the why. What actually causes these things? What's the etiology?
Well, often it's kind of idiopathic, meaning we don't always find one single definite cause.
Right.
But common triggers are things like trauma from passing really hard or large stools. Think of it like stretching the lining too much.
Makes sense.
Chronic constipation is a really big factor. And maybe surprisingly, chronic diarrhea can also play a role.
Okay, hang on. Hard stools, I get that. Stretching, tearing. But how does diarrhea cause a fissure?
It's more about the repeated irritation, you know? Constant inflammation of that sensitive skin can weaken it, making it more prone to tearing.
Ah, okay. So repeated irritation. Now, I know we classify them based on how long they've been around.
Yeah, that's right. If it's been less than 6 weeks, we call it acute.
Mhm.
If it's sticking around for 6 weeks or more, then it's classed as chronic.
Acute versus chronic. Got it. And is there another way we classify them based on, like, the underlying reason?
Yes, primary versus secondary. Primary is when there's no other obvious medical condition causing it, and these are actually quite common.
Okay.
Secondary fissures are, well, secondary to something else, like chronic constipation, maybe inflammatory bowel disease, IBD, like Crohn's, or certain STIs even, rarely, something like rectal cancer.
That's a really important difference. So for those primary ones, the ones without an obvious link to another condition, what's the main mechanism people think is at play?
Often it comes down to increased anal sphincter tone. Basically, the sphincter muscle is too tight, and that tightness reduces blood flow to the area that's ischemia. Poor blood flow makes it really hard for the tear to heal.
So it's a vicious cycle.
Exactly. The tear causes pain, the pain makes the muscle spasm and tighten even more, which cuts off blood flow, which stops it healing. The body's trying to protect itself, but actually makes it worse.
Wow. So breaking that cycle is the key for treatment then.
Absolutely. That's the core principle, really. Reduce that excessive tone.
You mentioned children earlier. Does this tightness thing apply to them too?
Yes, and a common thing in kids is withholding stool because it hurts, which of course makes the constipation worse, leads to harder stools, more trauma. You see the cycle again.
So it always seems to come back to that anal tone. Reducing it is the main aim of management.
Pretty much. Whether it's creams, lifestyle changes, sometimes even surgery, a lot of it is geared towards relaxing that sphincter muscle, improving blood flow, and letting that fissure heal.
Okay, cause is covered. What about risk factors? What makes someone more likely to get one?
Well, the risk factors really echo the causes we just talked about. So definitely chronic constipation
Makes sense.
and the straining that often goes with it. Diarrhea, as we said, through irritation. Inflammatory bowel disease can make the tissue more fragile.
Huh?
And interestingly, childbirth is another one, probably just due to the physical stress on the area during delivery.
Right, childbirth. That's one you might not immediately think of.
Yeah.
So a lot of it comes down to things that disrupt, well, smooth passage of stool. Keeping things regular seems key.
Absolutely paramount. Okay, so we know the what, the why, the who's more likely. Let's zoom in a bit on the how, the actual process in the body, the pathophysiology.
Yeah, what's the sequence of events?
It typically starts with some kind of injury or trauma to that delicate anal lining. Like we keep saying, passing a hard stool is a classic example.
Okay.
That initial injury triggers inflammation locally. And crucially, as we discussed, this trauma inflammation often leads to that increase in the internal anal sphincter tone, that tightness.
And the tightness reduces blood flow.
Exactly. That increased pressure impairs blood flow right where the tear is. And poor blood supply, ischemia, just hinders the body's natural healing process.
So that keeps going.
If that cycle of injury, high tone, and low blood flow continues, an acute fissure can turn into a chronic one that just won't heal easily.
A bit of a downward spiral then. Okay, so if someone presents with that kind of anorectal pain, how do we tell it's a fissure and not something else? What are the main differentials?
Good question. Really critical. Several things can feel similar. Hemorrhoids are very common, especially if they get thrombosed, meaning a clot forms in them that can be really painful.
Right, biles.
A perineal abscess, that's a collection of pus near the anus, definitely painful. Inflammatory bowel disease like Crohn's can cause anal symptoms, including fissures sometimes, so that's on the list.
Uh-huh.
And less commonly, but we have to consider it, anal cancer can sometimes present with pain and bleeding. Basically, anything causing pain or bleeding down there needs thinking about.
Okay, those are the big ones. Anything else that might mimic it?
Yeah, a few others. Proctitis inflammation just of the rectal lining can cause discomfort. Perianal sepsis, which is a broader infection, would obviously be painful.
Right.
And then there's a funny one called proctalgia fugax. That's characterized by sudden, really severe, but very brief episodes of rectal pain. The pattern is quite different from fissure pain, which tends to be linked to bowel movements and can linger.
That's helpful, knowing what else is on the differential list. Yeah. Okay, shifting gears slightly, how common actually are anal fissures? What's the epidemiology look like?
They're actually pretty common. Here in the UK, the estimate is about 11% of people will have one at some point in their life.
Wow, 1 in 10, roughly. That's quite high. Is it more common in certain age groups?
It can happen at any age, really, but we see it most often in younger adults. Sort of. 20s to 40s is the peak time.
Okay.
Interestingly, primary fissures, the ones without another cause, are a bit less common in older people. If an older person gets one, you might be a bit more suspicious of a secondary cause.
And gender? Any difference between men and women?
Nope. Seems to affect men and women pretty equally.
Okay. And acute versus chronic, which do we see more of?
Acute fissures are definitely much more common, which kind of suggests that often they heal up on their own or with simple measures, you know?
That is somewhat reassuring.
Yeah.
Okay, let's get back to the patient experience. What does it actually look and feel like? The clinical features, signs, and symptoms.
Right. So the main things we've touched on, that pain with bowel movements is number one. Then the bright red blood, usually seen on the paper after wiping, rather than lots in the bowl. And people might also mention itching or just a general discomfort around the anus.
And the pain you mentioned is sharp. Is there a typical description people give?
Yes, the classic one you hear is like passing shards of glass. It can be really intense. And importantly, the pain often hangs around for quite a while after the bowel movement, sometimes for hours. That post-defecation ache is quite characteristic.
Right, that prolonged pain is a big clue. And the bleeding always bright red.
Yeah, pretty consistently bright red, which again tells us it's coming from low down near the exit, fitting perfectly with a fissure.
Okay, so someone comes in with these symptoms. What's crucial to ask about in the history?
You need a really thorough history. Definitely ask about bowel habits and detail constipation. Diarrhea, any recent changes, straining.
Got it.
Ask about other symptoms too. Any abdominal pain, weight loss, rectal discharge. Those might point elsewhere.
Yeah.
Family history is important. Any IBD or bowel cancer in the family.
Right.
And it's a sensitive point, but especially in children, if there's no clear history of hard stools causing it, you do have to gently consider non-accidental injury as a possibility.
That's a very important consideration, especially with kids.
Yeah.
Okay, what about the examination? What are we looking for?
Well, you'd start with an abdominal exam, just checking for any masses, enlarged organs, maybe signs of constipation like fecal loading. Then, the anal exam itself. Often you can actually see the fissure just by gently parting the buttocks. It looks like a linear split, usually, as we said, in that posterior midline position.
So you might not even need to do an internal exam initially.
Exactly. Especially initially, a digital rectal exam, or DRE, is often avoided because it can be incredibly painful for the patient. You don't want to cause unnecessary distress if you can see the likely diagnosis externally.
Makes sense. Can the appearance tell you if it's acute or chronic?
Yes, it often can. Acute fissures tend to look quite fresh, like a simple tear with clean edges. Chronic ones might look a bit deeper, maybe the edges are raised, and sometimes there's a little external skin tag nearby, often called a sentinel pile.
Sentinel pile, okay. And what if it doesn't look like that typical midline fissure?
Right, if you see multiple fissures, or if they're off to the sides, lateral, or look irregular, that should make you think harder about a secondary cause like Crohn's disease or an infection.
So it sounds like diagnosis is mainly clinical, based on the story and what you see.
Primarily, yes. History and careful inspection are usually enough.
Are there times when you would push for more investigations early on?
Yeah, definitely. If there are red flags or risk factors for other things, like known STIs, diagnosed Crohn's, any suspicion of cancer, maybe associated skin conditions like psoriasis, or if the story is just a bit unclear or if simple treatments aren't working, then a gentle DRE might become necessary later to rule out other things.
Okay, so history and visual inspection first, maybe a DRE later if needed. What about more specialized tests? When do they come into play?
Usually they're reserved for situations where things aren't getting better with standard treatment, particularly for chronic fissures or if there's a query about the sphincter muscles themselves.
Like what kind of tests?
Well, one is anal manometry. That actually measures the pressures inside the anal canal, the resting tone, and squeeze pressure. Interestingly, sometimes in chronic fissures, the resting pressure might actually be low, which could suggest a different problem.
Oh, that's surprising. Not always high pressure then.
Not always, no. Another test is an anal ultrasound, endoanal ultrasound. This gives a picture of the sphincter muscles themselves, looking for any defects or damage. Again, usually considered if conservative measures fail in chronic cases.
Okay, so those are more second line. Let's talk about management then. How do we actually treat these?
Right, the goals are pretty clear. Relieve the pain, help the tear heal, and stop it coming back.
So pain relief first.
Yes, simple things like paracetamol or ibuprofen can help take the edge off, and topical local anesthetics like lidocaine cream can numb the area temporarily, which can be really helpful for severe pain, especially around bowel movements.
Makes sense. And for actually healing the fissure, what's the foundation?
Lifestyle and diet are absolutely key. Number one is increasing dietary fiber. Think whole grains, fruits, vegetables. This softens the stool, makes it easier to pass, less traumatic.
And the fluids.
Crucial. Plenty of water helps that fiber work properly. And then there are sitz baths.
Sitz baths. Tell us about those.
Basically just sitting in a shallow bath of warm water for maybe 10, 15 minutes, a few times a day if possible. It's soothing, relieves pain, and really helps relax that tight anal sphincter muscle.
Sounds quite nice, actually. What about specific creams or ointments?
Yes, there are specific topical treatments aimed at relaxing the sphincter and improving blood flow. Glyceryl trinitrate, or GTN ointment, is a common first-line one.
Okay.
There's also topical diltiazem, usually a 2% cream. Works similarly by relaxing the muscle, generally avoided in pregnancy and breastfeeding, though.
Good to know. Any others?
Nifedipine, which is a calcium channel blocker, can also be used. Sometimes as tablets, but often as a topical cream, too. Again, to relax the sphincter.
So quite a few topical options. Are there other non-surgical approaches?
Yes, botulinum toxin Botox injections can be used. Injecting it into the internal sphincter temporarily weakens the muscle, giving the fissure a chance to heal.
Botox, interest.
And of course, really reinforcing those lifestyle changes, keeping up the fiber and fluids long term, is vital. For a lot of people, this conservative approach, combining everything we've mentioned, works really well.
So surgery isn't the go-to straight away.
Definitely not. Surgery is usually kept for cases where conservative management just hasn't worked after a decent trial, maybe 6 to 8 weeks or so.
And what does surgery involve?
The most common operation is called a lateral internal sphincterotomy. The surgeon makes a small cut in the internal sphincter muscle to permanently reduce its resting tone.
Does it work well?
It's generally very effective at healing the fissure and preventing recurrence. But there is a small but significant risk of long-term problems with bowel control, like minor leakage in some patients. So it's a trade-off that needs careful discussion.
Right, potential side effects. Are there other surgical options?
Yes, there are others like posterior or bilateral sphincterotomies, fissurectomy, cutting out the fissure, or procedures like anterior levatorplasty. An older procedure called manual anal stretch isn't really recommended anymore because the results were unpredictable and it could cause damage.
Okay, so a range of options from simple to more complex. When should someone be referred to a specialist?
Good question. For kids, if a fissure isn't healing after about 2 weeks of trying simple things, referral is sensible.
Okay.
For adults, referral should be considered if they're still having significant pain after about 6 to 8 weeks of proper conservative treatment,
Mm,
or if they keep getting recurrent fissures despite doing all the right things.
right.
And also, older patients with persistent fissures or any slightly unusual symptoms might warrant referral to rule out underlying issues.
And what happens in secondary care, typically?
Specialists will review the diagnosis, perhaps optimize the topical treatments, maybe try diltiazem if GTN failed, or consider botulinum toxin injections. And obviously, they're the ones who discuss and perform the surgical options if needed.
But surgery is rare in kids, you mentioned.
Very rare. They almost always respond well to the conservative measures eventually.
Okay, good. So we know how to treat them. What's the general outlook? And the prognosis.
For acute fissures, it's generally pretty good. Most heal up within a couple of weeks with the right conservative steps, though some might take up to 6 or 8 weeks.
But they can come back.
Yes, recurrence is quite common. Maybe up to half the people treated successfully with something like GTN might get another one later on. Overall, non-surgical management probably heals about half of patients effectively, especially if they stick with the lifestyle changes.
And for children, the key is early intervention if it's not healing.
Exactly, mainly to stop that cycle of pain and stool withholding becoming entrenched.
Makes sense. What about those secondary fissures caused by something else?
Their prognosis really depends on managing the underlying condition, like the IBD. Get that under control, and the fissure might heal too.
And for chronic fissures needing surgery, like that sphincterotomy.
The prognosis for healing the fissure itself is excellent with surgery. High cure rates, low recurrence. But you always have to balance that against the small risk of long-term continence issues we mentioned earlier.
Okay, so mostly a positive outlook with the right approach. Are there any potential complications we should be aware of, even if they're rare?
Serious complications are uncommon, thankfully. But theoretically, you could get an infection developing in the fissure, potentially leading to a perineal abscess. And very long-standing chronic fissures could rarely lead to some scarring and narrowing of the anal canal. That's anal stenosis.
Okay, so rare but possible. Good to know. All right, let's try and wrap this up. Can we quickly summarize the absolute key takeaways for listeners revising this?
Sure. So anal fissures, small tears, usually posterior midline, caused often by trauma, hard stools, and increased sphincter tone leading to poor blood flow.
Yeah.
Key symptoms. Sharp pain with defecation, often lasting afterwards, and bright red bleeding on wiping. Risk factors include constipation, straining, diarrhea, IBD, childbirth, mostly clinical history and gentle inspection. Avoid painful diarrhea initially.
Management.
Focus on pain relief, softening stools, fiber, fluids, relaxing the sphincter, sitz baths, topical GTN, or diltiazem. Botox and surgery, sphincterotomy, are options for resistant cases.
And prognosis.
Generally good for acute fissures, though recurrence is common. Surgery is effective for chronic fissures, but carries a small risk to continence.
Perfect summary. So the bottom line is, while this pain and bleeding can be really worrying, many fissures do get better with simple steps. But, crucially, always get it checked out properly by a healthcare professional for the right diagnosis and management plan.
Absolutely. And if you are revising for exams or just want more solid resources, do check out passthemsra.com and freemsra.com. Lots of useful stuff there.
Great. And maybe a final thought. Really understanding these common conditions like anal fissures, even though they might seem straightforward, is so important. They cause real distress for patients, and knowing the ins and outs helps us provide much better care.